Good morning, everyone. Thank you very much. My colleagues attended the Hepato Pernambuco 2021 Liver Talks webinar. It's an honor to begin this scientific event today with a liver talk, hepatocellular carcinoma, involving the concepts of therapy. It's also great pleasure to have my friends Dayse Aroucha from Pernambuco and Dra. Cássia Leal from Rio de Janeiro, who will moderate this round table and will introduce the international speakers, debaters, and presenters of clinical cases. We also prepare a small tribute to celebrate Hepato Pernambuco 2021 Silver Jubilee. Welcome to Liver Talk today.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Okay, let's going to start. I'm going to introduce my colleagues, Professor Dayse Aroucha. She's a associate professor from gastroenterology department in University of Pernambuco, and she's a coordinator of ACC outpatient clinic in the Institute of Liver Study of Pernambuco. Dra. Cássia Leal, she's a coordinator of the outpatient ACC from Hospital Federal dos Servidores do Estado do Rio de Janeiro. She's a pathologist of University Federal of Fluminense. She's going to moderate and present all the debaters and the case presentation, please. Welcome, my friends.
Hello, everyone. First of all, I would like to thank Dr. Leila for inviting me to this conference. It's my pleasure to participate in this event with this great team. For the first presentation, I would like to invite Dr. Sherrie. She is a specialist in gastroenterology and hepatology and co-investigator of many trials in primary liver cancer. She is from Milan. Please, Dr. Sherrie.
Well, good afternoon, everybody. And I'm feeling very honored to be invited in this very important milestone with colleagues that have made the history of liver transplantation and have helped to grow the field of liver transplantation in the world. To talk to you about this particular topic that has been given me, which is the road I have traveled with HCC. So actually, before starting, I would like to talk about something of my personal road, because the roads of HCC and my personal roads just cross together. I was born in 1973 in India by a very loving family, which I have the fortune of having with me again. And they always told me that since I was small, I had my own surgery. This is my first surgery. I had loads of patients that crowded my surgery. And my sister's dolls were operated by me very often. And unfortunately, their prognosis was dismal. Education and formation were and still are part of my life. As you can see here, nothing has changed in 40 years. Graduation was one of the happiest days in my life because I had it very clear that I wanted to find a mentor that could help me convey the massive amount of positive energy in something useful. I wasn't afraid of the difficulties. I wasn't afraid of the barriers. In end of 1990, I came across transplantation for hepatocellular carcinoma in an oncological dedicated institute, having as a mentor a very unique person, which is Professor Mazzaferro. It is very difficult not to fall in love with liver transplantation. It is a perfect blend of all medical specialties, perfectly tuned together, in which the transplant hepatologist is very often the orchestra director. Now, the first impression you get when you get close to liver transplantation for HCC is that this is an extreme procedure, and it should be reserved for patients with an extreme oncological condition. You think that the physician has the right to decide whom to give the transplant, and the more extensive the tumor, the better and easier the allocation. This is very far from being true. During my road with liver transplantation, I actually got to learn that HCC is an organ-addicted cancer. That means that for most of its life, it develops within the liver, making direct therapies the best choice for HCC. Surgery, and above all liver transplantation, are able of removing both the cancer and the cirrhotic liver parenchyma. And here, you get to understand that medical treatments which are innovative and which are very promising will never be able to substitute the curative potential of resection and of transplantation. During the road together with liver transplantation, you get to learn that the graft resource is not just of your patient, but it is of all patients, whether or not they are affected by HCC, by liver decompensation, by intractable itching. The graft is not ours. The graft is of the medical society and of all our patients. And this is why survival after liver transplantation for HCC should be the same as the survival of patients within the waiting list from non-oncological purposes. In order to guarantee a very good 5-year survival, we have to therefore select, and we have to select patients with initial tumor. These are the Milan Criteria, single nodule up to 5, 3 nodules up to 3 centimeters. Quite biased if I talk great about the Milan Criteria, but just to say that with more than 6,000 citations, Milan Criteria have been introduced in most of the allocation policies throughout the world. This is a meta-analysis showing that Milan Criteria is the best for what regards treatment allocation. But living with liver transplantation, you get to learn that the transplant community is always on the move to find the way of serving the most patients in the best of ways. This is why in the last 10 or more years, we have been looking for extended criteria. That means transplanting even more criteria with a little bit more extended tumors, but trying to have a survival which is very similar to those within the Milan Criteria. In the upper side of the screen, you find the extensions which have been suggested using size and number, morphologic parameters. And on the lower side of the screen, you find actually size and number enriched by AFP, because we finally understood, working with liver transplantation, that the biological features of the behavior of the tumor are as important as morphological features, that means size and number. And AFP has also been incorporated in important prognostic scores, such as the French model and the Metro Ticket 2.0, which take into consideration the sum of the number and the diameter of the lesions and also the level of AFP. When you live and you walk together with liver transplantation, you learn that one size does not fit all. All these suggestions for extending criteria have to be adapted to every single center in the world, because this has to be balanced with two important features: the availability of the graft and what is the minimal outcome considered acceptable in every center. Conventionally, the minimal accepted survival after liver transplantation has been recognized to be approximately to 50 to 60%. And according to the organ availability, more living donors, more cadaveric donors, this can actually move. Working with liver transplantation, you also learn that if you increase patients on the waiting list, that means extending your criteria, you risk to increase also the waiting list, and you increase the dropout rate because of tumor progression. That means that you risk to increase the mortality on an ITT basis. This is why you learn that the downstaging concept is of paramount importance. That means treating on the waiting list patients in order to reduce the probability of tumor progression. This is the very first endpoint of downstaging protocols. The second important concept is that with downstaging, we may have patients who respond and patients who may not respond. Patients who respond are patients which are worth transplanting, because response to downstaging is a very powerful tool for patient selection. Now, how do we know this? We know this because the histology of patients who do respond to downstaging protocols, that means treatment while on the waiting list, are patients that at histology have the same characteristics of patients within Milan criteria: absence of microvascular invasion, absence of satellites, and low tumor grading. These are all the various proposals that have been suggested in literature to downstage your patients. As you can see here, the 5-year overall survival is very variable. It goes from 90 to 40%. And the extreme diversity in the 5-year overall survival should be looked into the different entry criteria, mostly no macrovascular invasion and no extrahepatic spread, but of course, very different and very variable, and also different in the endpoint of downstaging. Shall we just treat a patient? Shall we treat a patient till the patient gets into the Milan criteria? Shall we treat a patient until the AFP goes down to normal values? For what regards the entry criteria, just remember, and this is a UNIS experience, that patients who are downstage and who are transplanted, starting from specific entry criteria, do much better than patients who are all comers and then are downstaged. That means that we have to have a specific entry criteria. For what regard endpoints of downstaging, it is true that it is worth reconducting patients within the Milan criteria, but probably we should have a more oncological perspective, and we should try to just make do with radiological response. What is the secret of downstaging? Are we just increasing the transplant list? Are we transforming downstaging into recurrences? This is a very important feature and question that goes over on time. Or are we really giving a benefit to our patients? The question to this, the answer to this question has to be looked to in the XXL trial, a very demanding study that was published last year after 10 years of work, the very first trial randomizing in liver transplantation. Patient randomized to transplantation or non-transplantation after successful downstaging. Just look at the results in terms of recurrence-free survival, upper side of the slide, and overall survival, lower part of the slide. In red, transplantation, in blue, non-transplant therapies. As you can see, if you transplant a successfully downstage patient, you have a massive benefit both in recurrence-free and in overall survival. That means that apart from size and number, apart from AFP, also downstaging is a very perfect tool to select our patient. What does downstaging mean? Means whatever kind of treatment in whatever combination in the time that's decided by the physician itself. There's no limit to treatments, to combinations, or to time of treatment. In the XXL trial, you can see that patients were resected, underwent Dayse, underwent radioembolization, underwent ablation. But the clinical and therapeutical armamentario of HCC is increasing, and you all know by the EMBRAVE study, and we know now that immunotherapy can be an adjunctive treatment also for HCC. So probably this could be a good option also for downstaging of patients. Let me please remind you that there have been some important concerns in treating patients with immunotherapy before transplantation. This is one of the first case reports of a fatal acute hepatic necrosis in the immediate postoperative period, and this was strictly related to immunotherapy because there was a very strong PD-L1 staining, and this created some concerns. This very sharp observation was blunted by further observation. This is a very good case report coming from Mount Sinai. 9 patients treated with just immunotherapy before transplantation in a downstage project. Just note that patients were treated within 4 weeks from transplant. Patients were treated with a very omnicomprehensive immunosuppressive regimen in order to avoid rejection. No rejection, no tumor recurrence, and no death with a median follow-up of 16 months. And what is also very interesting is that 1/3 of the patients had a more than 90% complete necrosis. Those patients were just treated with nivolumab. Now we know that the trick is to combine immunotreatment with another compound for 2 important reasons. We are able of increasing antigen exposure. This is one point. And we are able to modulate the microenvironment and reduce tumor escape mechanisms. So probably if we add to nivolumab other compounds, we do even better. This means that with immunotherapy, we may have an extreme downstaging, not just from intermediate patients to Milan criteria, but from advanced patients to Milan criteria. And this is why we can maybe improve our transplant capability. 2 last slide. I've learned during this walk that the multidisciplinary management of HCC is crucial, but someone at a certain point has to take the microphone, has to decide, and has to take the responsibility. And the very last slide is that transplanted patients are like diamonds. They are forever, inside and outside the ward. We work for them, but they work for us. They transmit energy and they transmit positivity. These are my conclusions. The Milan criteria are the benchmark for patient selection, but we are also trying to extend the criteria in order to transplant always more patients. The most important concept is that transplanting patients with HCC should give us the same outcome of transplanting patients on a non-oncological waiting list. Downstaging has been for long adopted, and the real intent of downstaging is not just to treat the patient on the waiting list, but to have a tool for selecting patients. The XXL has given strength to justify the downstaging protocols. HCC is a very good target for immunotherapy together with other compounds, combination of immunotherapy. And this is actually a very important instrument we have to increase the possibility of downstaging. We just have to identify what the patient has to do for avoiding rejection. Of course, we are missing of prognostic markers. And this is the key issue that differentiates HCC from other oncological condition. Multidisciplinary team is the key of success, and at last, for the patients and with the patients. This is the slide I decided for my lucky road. Again, I'm a lucky person, I must say this. I got this picture from a metaphor of a patient, a transplanted patient, which left us some time back. He said that his road was like this, full of curves and full of tunnels, but always at the end of the tunnel, you'll find the light. And I would like to end this presentation thanking Marco Arnone for everything he gave us. Thank you very much.
Congratulations, Dr. Sherrie, on your amazing presentation. I'm sure the points you discussed will be very important for the next presentation. Now, Dr. Dayse will present the next speaker.
Vou apresentar a doutora Aline Chagas, de São Paulo, para o caso clínico. Mas antes, eu gostaria de parabenizar, Leila, pelos 25 anos, né, do Hepato Pernambuco, né, e também dos 15 anos da nossa casa, o Instituto do Fígado de Pernambuco. Obrigado pelo convite. A doutora Aline Chagas é coordenadora da equipe de hepatologia do Instituto do Câncer do Estado de São Paulo, da Faculdade de Medicina da Universidade de São Paulo, coordenadora da equipe de gastrohepato do Hospital São Luís Anália Franco, Rede Dor. Cássia? Cássia não, Aline, desculpa.
Bom, boa tarde a todos. É uma honra estar participando dessa mesa com tantos experts na área de carcinoma hepatocelular. Agradeço à comissão organizadora, em especial a Leila, pelo convite. É um prazer estar aqui nos 25 anos do Hepato Pernambuco e espero que no próximo estejamos presentes todos juntos, né, Leila? Bom, este é um paciente de 65 anos, sexo masculino, raça oriental, e ele nasceu e mora em São Paulo. Esse paciente ele vinha sendo acompanhado, na verdade, pelo time cirúrgico, por uma história de apendicectomia há 20 anos atrás. Numa tomografia abdominal, em 2011, foi visto o nódulo hepático. Entretanto, esse paciente perdeu o segmento na instituição e voltou apenas em 2013, onde a equipe cirúrgica solicitou uma nova tomografia para reavaliar esse nódulo hepático. Além da história de apendicite, era um paciente que tinha síndrome metabólica, ele era hipertenso, era diabético, tinha hipertrigliceridemia e obesidade. Ele não relatava história de hepatopatia, mas nem de alcoolismo, nem de etilismo. Esse é o primeiro exame de imagem dele, onde a gente via um nódulo pequeno de 1 centímetro em segmento 8. Foi uma tomografia feita com apenas uma fase, a gente só tinha a fase portal, então foi considerado um nódulo indeterminado naquela ocasião. Como eu expliquei, o paciente perdeu o segmento e quando ele retornou, foi solicitado um estudo trifásico, onde foi visto um crescimento do nódulo no segmento 8, que agora media 2 centímetros, era um nódulo que tinha um realce persistente e periférico, e isso tornava um nódulo suspeito, mas ainda indeterminado. A gente observa aqui o crescimento da lesão de 2011 para 2013. Em termos de exames complementares, e vale ressaltar que no exame de imagem já dava para ver sinais de hepatopatia crônica que sugeriam já um quadro ou de uma hepatopatia crônica mais avançada ou de uma cirrose. Em termos de exames complementares, a alfa-fetoproteína era normal e a função hepática também. Foi feita investigação de outras causas de doença hepática, visto que tinha sinais de hepatopatia crônica na tomografia e foram afastadas causas virais, causas imunes e causas metabólicas. E na endoscopia a gente já via varizes de esôfago de fino calibre. A contagem de plaquetas também era normal. O caso, então, foi discutido em reunião multidisciplinar e, sendo um paciente com a cirrose provavelmente associada a esteatohepatite não alcoólica, Child A, com a hipertensão portal leve, mas com plaqueta ainda normal, e era um nódulo que não preenchia todos os critérios para carcinoma hepatocelular, já que não tinha o washin ou washout, mas era um nódulo suspeito, e entre as outras possibilidades diagnósticas, pelo crescimento e pela suspeita de malignidade, a gente tinha colangiocarcinoma ou hepatocolangiocarcinoma. Então, ficou entre esses 3 diagnósticos diferenciais, CHC, colangio e hepatocolangio, e diante dessa suspeita de malignidade, foi optado por uma ressecção cirúrgica da lesão como tratamento. O paciente foi, então, submetido a uma ressecção cirúrgica em agosto de 2013 e foi confirmado o diagnóstico de carcinoma hepatocelular moderadamente diferenciado. Não existia já a presença de uma invasão vascular microscópica, as margens estavam livres e também foi confirmado nessa peça a cirrose secundária à doença hepática gordurosa não alcoólica. Bom, 3 meses depois da cirurgia, foi observado um novo foco hipervascular, no segmento 5/8, que não tinha um washout evidente de 2 centímetros, que não existia nos exames pré-operatórios. Foi solicitado para esclarecimento do diagnóstico desse nódulo uma ressonância com contraste hepatobiliar, que não demonstrava também um washout na fase de equilíbrio, mas era hipocaptante na fase hepatobiliar, levantando a suspeita de uma recidiva de carcinoma hepatocelular. Então, era um paciente com cirrose por NASH, ainda mantinha a função hepática preservada, Child A, que tinha sido submetido a uma cirurgia, uma ressecção, e que estava com a suspeita de recidiva do carcinoma hepatocelular em segmento 5/8. Nós discutimos novamente o caso numa reunião multidisciplinar, e foi optado por inclusão do paciente em lista de transplante e realização de tratamento ponte com quimioembolização. Foi contraindicada a radiofrequência pela localização da lesão muito próxima ao hilo, então por isso optamos por quimioembolização. Foram tentadas 2 quimioembolizações, apesar disso o paciente não teve uma boa resposta, TASSE, mas manteve doença estável, sem progressão. Tinha um outro foco que surgiu, mas não preenchia critérios ainda para carcinoma hepatocelular, era bem pequenininho. Foi optado, então, por injeção percutânea de etanol da lesão, e ele apresentou, após 3 sessões, uma resposta parcial. E esse paciente foi, então, submetido ao transplante de fígado, que confirmava que realmente aquela recidiva era um carcinoma hepatocelular, com 40% de necrose, medindo 2 centímetros, e ele apresentava aquele outro foco, também foi confirmado como CHC bem diferenciado, em segmento 5, e não tinha invasão vascular no explante, e hoje o paciente ainda continua vivo em segmento no nosso ambulatório de hepatologia. Eu vou trazer para vocês algumas questões, vou passar a palavra agora a Cássia e a Dayse, para poder moderar essas questões junto com nossos debatedores. Obrigada.
Então, agora eu vou obrigada, Aline, pelo excelente caso, né? E vou apresentar os debatedores. O professor Flair Carrilho, de São Paulo. O professor Flair é o professor titular e chefe do Departamento do Serviço de Gastroenterologia da USP. A professora Ilka, de São Paulo, é professora titular da Universidade Estadual de Campinas. E a doutora Cristiana Tavares, de Pernambuco, é oncologista, MD, MS, do NEO Rede DOR do Recife e do Hospital Universitário Oswaldo Cruz, da Universidade de Pernambuco.
Okay, Sherrie, please join us.
Yes, I'm here.
The questions.
Well,
Okay.
the very first question was if we are all aligned on the therapeutical decision taken on this patient.
Yes, in the first time, if you should do something different or you choose for a resection, what do you think about it?
Well, patient was 65 years old when he had a diagnosis. That's a little bit a very critical age to decide on transplantation or not. This is the first important point. You decided 65, which is the cutoff for a very critical decision. I think that you did absolutely right, because the doubt between an HCC, a CCC, and a mixed tumor was critical. there is evidence in a very good clinical outcome in transplantation, both for HCCs and for CCC within 2 centimeters. And there are also trials which are trying to increase also the dimensions of the cholangiocarcinoma. But we all know that mixed forms have a very detrimental prognosis. So surgery for diagnosis and treatment was absolutely a very good choice. The recurrence was very close, so that was a signal that we had to change our strategy. And I agreed that that patient had his very last chance to be transplanted at that point. So I would have done the very same thing.
Ilka, you can comment as a surgeon.
Yes, I'd pleasure to participate for this event. For congratulations for Dr. Leila for 15 years and 25 years. The Pernambuco Liver Institute, congratulations again. And for this participation. It's very important that Sherrie comments about the resection, liver resection for a tumor, for HCC tumor. There are a new concept about Dr. Gelli, Maximilian, and Daniel Cherki about when put the patient in surgery, liver resection or transplantation. In this patient, through some criteria, is over 60 years, is already one only tumor. The tumor is not so great, and the fibrosis is in the image exam is HCC or CCC, but it's a perfect match, and the AFP is low than 100. And the 3 concepts for 1-0 score, for the Daniel-Cherki score, is the best one for the liver resection choice. It's very important to remember the number of the relapse or recidive the HCC after 5 years is around 50% in the patient with HCC, because the tissue or in NASH or in another kind of cirrhosis, the liver resection had a good choice in this case.
Okay, and in patients with
Dr. Sherrie.
Yep, Professor Boyne, what do you think about resection as a downstaging procedure? I mean, if you remove the tumor, it seems as though patients don't need transplant anymore.
No, sometimes yes, sometimes no. Because the choice, the selection of the patient for liver resection is the main of the schedule. What kind of patient is the status clinic of this patient, heavy hypernatremia or not hyponatremia, heavy child A or male under, this is criteria, male under 10, is this important for this patient?
And I ask Professor Carrillo.
Yes, please. Yes, please.
Yes. I agree with the first, well, first of all, I would like to thank for the kind invitation for participate of this event. And congratulate to Leila and the people from Pernambuco for the 25 years of the meeting, and then 15 years for the institute. And it's a great pleasure for my department to participate in this event. I'd like to call attention that I agree with the first indication, the section, but I would like to ask to Dr. Sherrie and for others. Under section was observed that there was a microvascular invasion. Then if we have microvascular invasion, maybe we have a good chance to have a advanced HCC. And then, of course, I participated in that multidisciplinary decision, maybe in this case, to indicate the liver transplant. But I would like to hear from Dr. Aboin and Dr. Sherrie from Massaferro group, from Italy group, if you indicate the liver transplant in a patient with 65 years, with a NASH, cirrhosis, and a microvascular invasion, what do you think about this problem?
Dr. Sherrie, you first.
Yeah. Well, the indication for metabolic syndrome is becoming the most important, at least in Europe and in Italy. So actually, considering that 40% of our waiting list is HCC, probably most of it is now metabolic syndrome. I wouldn't discard a patient just for microvascular invasion. I'm aware of the fact that lots of centers do discard a patient for indifferentiated G3 or for microvascular invasion. But I personally think that the overview of the biological behavior of the tumor is of paramount importance in determining whether a patient should be transplanted or not. That's why response to Dayse after the multifocal recurrence, the trend of the AFP were very important to decide whether to transplant this patient. I wouldn't discard it just for microvascular invasion. Surely macrovascular invasion for me is still a contraindication. This is not like this in recent perspectives in which also macrovascular invasion might be downstage, probably with immunotherapy and other combinations, but microvascular invasion is not a contraindication, at least in our center.
Okay.
Okay, and the next question was about how to...
Dr. Aline, we
Yes.
have a question from the audience.
Ilka.
Okay.
Can I make?
Yes, of course, Cássia.
Is everolimus indicate in this case for immunosuppression?
Yes, in our service, all the explant examined and histological specimen were revisited every time. And 10 years ago, I started the relapse is around the 89% of the relapse after HCC liver transplantation. And when this specimen shows macrovascular invasion, angiolymphatic invasion, multiple micronodules on the sub-centimeters, with sub-centimeters, introduced the everolimus for these patients. And apparently, the number of the relapse were down, up. But another question important is the time of, in this case, the time between the liver resection and show another kind of tumor. One was moderate, as another one is well differentiated. It's a different tumor in the same liver. It is an important question too. It probably after the injury caused by liver resection, another tumor grow up. But the number of the level of the AFP during the AFP core, according to Vo, the number this score is probably 1 or 0. In the good responses, probably is according to.
And what do you think about adjuvant therapy in this case? You think in the future, patient that we have resection and with microvascular invasion, the adjuvant therapy will be the filter in this case?
Probably. Probably nivolumab, probably when they get this medication, is the patient had 64 now, 65, and now after 3 years, 68, close to 70. Probably nivolumab or another kind of the immunotherapy, it's a good response for this patient, the better indication than transplantation, because the patient is 70, the patient is almost old, and the new therapies became at a good place and for in the future, close.
Probably to comment is something or leave this to the next case, the immunotherapy after Sangro.
Yes, congrats, Leila. It's a pleasure to be here. I like to congratulations for the presentation and the clinical case report too. It's so interesting. And I think it's important to talk here about the combination. For example, we could be ipilimumab and nivolumab, but it's a toxic combination. Then monoimmunotherapy is better than that. Now, I had a patient that was with renal carcinoma, and I treated with the combination, and this patient developed hepatitis, autoimmune hepatitis with the combination. It's normally occurs in 1 or 4%, and it's very difficult for us yet. Then monotherapy is easier is easier at the events adverse, it's easier to control, to follow up, but it's a 5-step of oncologies nowadays. It's immunotherapy. I agree that it's our future.
The issue of immunotherapy as an adjuvant treatment is very intriguing, because the secret of immunotherapy is antigen exposure. And after surgery, the antigen exposure is minimal. So probably the correct way of going will be start with a neoadjuvant, taking advantage of the bulk of disease and of the antigen exposure, and then carrying on after surgery. So probably we have to still balance whether a combination treatment is better after surgery or starting before surgery in a neo/adjuvant strategy.
Yes, I'm an apologist of neoadjuvant therapy. I really like this in any scenarios, and downstage in the data and the evolution of downstairs is very important, and I'm very happy with this kind of use of immunotherapy and advanced in treatment of cancer in hepatic carcinoma.
And it's very tolerable. I mean, whoever did the STORM trial of TKIs in adjuvant suffered 4 years with the patient. This is actually very, very tolerable.
I would like to talk here about the immunomediated cutaneous events adverse of immunotherapy, and 25% of patients that we treat with nivolumab or pembrolizumab could disinvolve grade 3 or 4 of immunomediated cutaneous. I don't know your experience in studies of downstaging but 4 cycles of nivolumab it isn't could present, but when we treat with 9 cycles, 8 cycles, upper than 9, the adverse events could be more clear and appear, and we have to pay attention in HASH, Stevens-Johnson's syndromes, and it's important to know about that.
I suppose that we are discussing after a surgical resection, not after a liver transplant. Yes?
Yeah.
Okay, of course.
Okay. So other question was how to choose the best way to evaluate the patient about the portal hypertension, to choose in patients BCLC A with early HCC and one nodule, how to choose from radiofrequency ablation, resection, liver transplantation, how you do in the practice to analyze the portal hypertension. The elastography has something to help us in deciding this. So it was the other question that I have to you. Professor?
Yes. Of course, the gold standard from Baveno 6 meeting decide that the gradient from the portal hepatic vein, the hepatic vein gradient is the gold standard. But in practice, in clinical practice, it's so difficult to have on clinical practice. Then we can use, for example, the elastography to decide if we have clinical significant portal hypertension. Then is an opportunity. I think that in this case, elastography would be a good choice to decide, because he has the patient has more than 100 is a good platelets count. There's small varices. Then maybe he has between 20-25 kilopascals. Then is a good you can use elastography to decide. And I think that was a good choice, the liver resection for this patient. I don't know if you
Yes.
Dr. Sherrie.
Dr. Sherrie,
Ilka.
Well, this is the need of a hepatologist in a surgical and transplant center.
Yeah.
I mean, we usually do omnicomprehensive study I think like most of you. We use elastography, we use indocyanine green dye, and we use volumetry. And we've been using for a couple of months now a hepatic scintigraphy to actually capture what is the future liver remnant and whether the future liver remnant has a sufficient functionality after resection. So there are lots of surrogates, as you said. So if it's not the HVPG, it's the varices, the volume of the spleen, and the platelet count, which are surrogates of severe portal hypertension. And putting all this data together, of course, the last responsibility is the surgeons. We decide whether the patient is a good candidate for surgery.
Yes, in Brazil in general, there are criteria for no liver resection go to the liver transplantation. And there are criteria according to SESCOM, is a no hyponatremia, no great portal hypertension, mild or not, cirrhosis instead F3 or F2 according to the elastography or another kind of exams, or including the image in MRI, child A or male under 10, no multiple nodules, or no resection involved 2 or more segments. And platelets is a good. The clinical labs, the platelets is good after over 100,000, and bilirubin, no joints, bilirubin under 2.
I ask about the bridge therapy. Do you believe that performing the bridge therapy for transplantation has an impact on survival and post-transplant recurrence? And can the response to bridge therapy be a predictor of tumor biology or post-transplant evolution? In our multi-center study that Ilka and Leila take part about liver transplantation and HCC, we saw that patients that have partial response or complete response to bridge therapy has little recurrence comparing to patients that don't have this response. And Sherrie talked about this in her presentation about downstage patients. And so we want to know about the patients inside Milan Criteria, if you believe that this treatment also had impact on post-transplant outcomes.
If the question is for me, I'm absolutely on board for bridging tumors. I mean, this is an oncological standpoint. If you were to wait to operate a pancreatic tumor for whatever reason, wouldn't you do chemotherapy to your patient? So this is an oncological perspective. Patients with a tumor have to be treated. Unfortunately, with liver transplant, you can't decide when the treatment can be given. This is why treating the patient, bridging, and even more downstaging has a meaningful effect. I'm sure about that.
Ilka, quer comentar também?
There are one point more, besides beyond the Sherrie's comments, it's important in Brazil because the waiting list is so long, after 6 months in São Paulo state. This is an interval, Halazun, 5 years ago, showing the paper that the time among the Dayse and after the liver transplantation over 6 months is the best time to study and to appreciate the behavior of the tumor. It's a new concept 5 years ago, but it's very important for us. And in another state from Brazil, the interval time between the waiting inserted the waiting list and the liver transplant is 1 month or 2 months. Is not so good. But the number in Brazil, there are, according to the National Health System of Transplantation, around 6,000 HCC patients transplanted. And the survival is around, in 5 years, 62%. 65% in around the 6,000 patients. But the time of this, because São Paulo responds of 70% of the number of the liver transplantation, is more than 4 months. And I believe that is a cause of the good response and even to downstage patients.
Thank you so much. I agree. Also, Professor Flair.
Yes, I think that we need to have, after the bridge therapy, we need to discuss if for example, for Dayse in this case, if we have had a complete response or a partial response. The size of the tumor, the child-pug scores, the biology of the tumor on the explantation, the lymphovascular invasion at the explantation, the AFP level, and the number of local therapies, regional therapies that was to decide if we will have a good response or survival after liver transplantation, because in this patient, for example, he's alive, but we have some data that he's not a so good candidate to have a good survival in the future, because he has he's had a moderate HCC, a steatohepatic pattern that we just now we are learning about this type or this kind of HCC in one, and will differentiate in another. No vascular invasion. Then I think that he's on the limit that we have a good or not response after liver transplantation in this patient. For me, I think that to have a kid to discuss.
Cássia, I think I have to move on to the other lecture, and I leave the Q&A questions for the next case. Could it be? Everybody agree with this? To keep our time, right?
Okay.
Thank you very much. I hope that you keep online with your eyes to the other talks and the next case presentation as well. Let's going to move on to the next speaker. It's my pleasure to introduce Professor Phil Johnson. He was my colleague in the King's College a couple of years ago. Phil was a senior lecturer in the time that I was there. Now he's a professor of oncology, Department of Molecular and Clinical Cancer Medicine, Institute of System and Integrative Biology, University of Liverpool. Phil, it's a pleasure to have you guys. And also, Phil, we're very happy to see the presentation in Wimbledon yesterday when the Sarah was congratulate for everyone.
Okay.
To see here as well. Congratulations to UK scientists to develop the AstraZeneca vaccine against COVID.
Yes. Yes, indeed. Indeed, a great triumph. Okay. So it is a great pleasure to be talking to colleagues in Brazil again. And this is a picture of where I work now, Liverpool, as we said, famous for the Beatles and its football team. And of course, its liver research. So what I'm going to talk to you about today is the ALBI score for HCC prognosis and how it's going to move forward. Please consider this a very informal presentation, and if you want to ask questions at any time, I'm very comfortable with that. So we start with the Charles-Pugh score. Charles-Pugh score is integrated into hepatologist genome. It is, of course, the absolutely standard approach to assessment of liver function. And all the people here today know Charles-Pugh very well, and I'm not going to spend my time going through it. Just to remind you that it ends up with 5 variables: bilirubin, albumin, INR, ascites, and encephalopathy. Each of these is scored, and that leads to a class A, B, or C. And you all know that very well. But I will remind you just how old this is. This entered hepatology on the day that I first visited King's College Hospital, London, in 1973. I'll remind you that the Charles-Pugh score was based on a grand total of about 30 patients. There is not one statistic in the entire paper. It was made up empirically by Pugh and Ian Murray-Lyon sitting at a bench just thinking about it. And they decided that was the scoring system that they were going to have. So as I said here, it's been the foundation of clinical hepatology for more than 50 years. So why do we need to change it? Well, there are several reasons. First of all, strictly speaking, it should only be used for people with cirrhosis, and not everybody with HCC has cirrhosis. It was developed entirely empirically, and many of the components, such as ascites and cephalopathy, are very subjective. And if you go back and look at ascites, you'll see that you're supposed to score 2 points for mild and 3 for moderate. And I ask you, how can anybody really distinguish between those two consistently? So it's very subjective. And in fact, if you look in the literature, there are more than 30 versions of the Child-Pugh score. And some variables score differently in different versions. So it's very difficult to apply consistently between regions and investigators. So there is a lot wrong with the Child-Pugh score. But the thing that is mostly wrong with the Child-Pugh score is that times have changed. Nowadays, most people with HCC have Child-Pugh cirrhosis. And the majority, and in places that do a lot of surveillance like Japan, nearly 75% of patients with HCC have Child-Pugh A5. And that is what the grade that all of you have. That is saying we do not acknowledge that these patients have any failure of liver function whatsoever. We don't acknowledge or take into account liver dysfunction when we're assigning stage or prognosis. So it's very insensitive. So how can we do better? Well, we can do better with the ALBI score. All that ALBI is a simple model to assess liver function in HCC. It only involves albumin and bilirubin, and that's why it's called ALBI, and it's readily translated into grades 1, 2, or 3. It's evidence-based because it was based on several thousand patients, and because we could show that the clinical features were redundant, and you could get all the information you needed just from albumin and bilirubin, it's completely objective and highly discriminatory. And I found this hard to believe, but if you look through PubMed, there's nearly 1,000 studies since it was published in 2015, and 99% of them are very positive. So how do you calculate the ALBI score or grade? There's 2 ways you can do it. This here is the actual formula, but if you want to do it easily, you just look at this pictogram, bilirubin across the top, albumin down the side, and you just look up where your patient links up. So if you've got a bilirubin of 40 and an albumin of 32, that gives you an ALBI grade of 2. Alternatively, we have a website down here in which all our prognostic models are available, and one of them is ALBI. You just put the 2 variables in and it will tell you what the ALBI grade is. So does the ALBI grade have practical benefit over Child-Pugh score? And I think it does. And here's 2 pieces of evidence. First of all, I've shown you survival curve here for patients undergoing curative treatment, patients undergoing TACE, and patients receiving sorafenib. And these are all patients who have Child-Pugh A. And you can see that if you split the Charles-Pugh A into ALBI 1 and 2, here and here, or ALBI 1, 2, and 3, there are dramatic differences in survival, even though they are all classified as Charles-Pugh A. And you can see how big the difference is. In patients undergoing resection, Charles-Pugh ALBI 2, 66 months survival, ALBI 1, twice as much. Same for TACE. ALBI 1, 26 months, ALBI 2, half that, ALBI 3, half that. And just the same for sorafenib, 12, 7, 3. So there are very clear differences within Charles-Pugh A. If you look at just Charles-Pugh A5, you get exactly the same thing. Hong Kong, Japan, England, all these patients, according to Charles-Pugh, have effectively the same population, as same survival as the healthy population. But you can see it gives you very clear discrimination. And there is a sophistication to the ALBI score called ALBI, where you add in platelets and you get even better separation. So this is from the International Bridge Study, 3,400 patients. Here's all the patients who are Charles-Pugh A5, and you can see that there is a very significant difference between ALBI 1, ALBI 2, and ALBI 3. So I think that in itself is a reason for using the ALBI score. To show you how useful the ALBI score can be, I'm showing you this figure from my colleague Toyoda. And what this does is it shows you how liver function in patients with HCC has changed over time. On the vertical axis is percentage, and it's going from 1980 to 2005. And you can see the percentage of patients with Charles-Pugh A has gone from 30% in the 1980s up to 70% by 2008. And now by 2020, it's well over 75 and nearly 80%. You can see the same things happened by AJCC tumor stage. The numbers in stage 1 has gone up. But notice that the big maximal tumor size, less than 2 centimeters, hasn't changed since the 1980s. This is the limit of the sensitivity you can get with ultrasound. And yet, despite the fact that they're not picking up early tumors, the overall survival is getting better and better. And that's because liver function is improving. Now, a much easier way to see that is, instead of Charles-Pugh class, to look at the ALBI score. And this is the ALBI score from 1970 to 2010. The blue line is tumor size, and you can see how dramatically surveillance has brought the typical tumor size down. But look at the ALBI score. You can see that from 1980, it's improved dramatically. So liver function is improving over time, and the ALBI score has sufficient granularity to demonstrate that very nicely. So survival is improving because liver function is improving over time, and that allows you more curative therapies. And ALBI has the granularity to show this very clearly. Now, you shouldn't believe models such as ALBI until they've undergone proper external validation. And that has been done quite extensively now with ALBI. So the first and big validation came from David Pinato and a big international group published in J Hepatology. And they concluded that in this multi-center study, the ALBI grade satisfied criteria for accuracy, reproducibility. in both Eastern and Western patients, and that consideration should be given to the ALBI grade as stratifying biomarker for liver reserve in routine clinical practice. And I think this will happen. This was based on something like 2,000 patients. The second validation was a meta-analysis of 23,000 patients in 32 studies. And again, it was very positive. High pre-treatment ALBI is closely associated with poor prognosis. And then the third validation came from a national study in 6,500 Korean patients. And they compared all the various scoring systems for prognosis in HCC. And they showed that PALBI and ALBI were more reliable than Charles-Pugh or MELD for assessing liver function. So it all looked very good, and the model appears to be perfectly validated. However, we should be cautious. In fact, there is no reason to believe that ALBI, or for that matter, Charles-Pugh score or MELD, have any liver specificity. Here are 3 typical papers. Believe it or not, preoperative ALBI score is a non-invasive and valuable prognostic marker for brain cancer patients, high-grade glioma. Here's a paper, ALBI score is suitable marker in acute heart failure. Third one, ALBI score is a simple and promising predictive factor in gastric cancer. So although ALBI seems to be very useful, it starts to look as if ALBI is really a non-specific index of ill health with no liver specificity. Nonetheless, its role within hepatology is expanding quite dramatically. Here's a subsequent paper that shows very clearly that ALBI is better than Charles-Pugh score in simple, uncomplicated cirrhosis. Again, big multi-center study, ALBI score accurately predicts the severity and long-term prognosis of patients with hepatitis B related liver cirrhosis, and it's superior to MELD. In clinical trials, I haven't got the published data yet, so I'm not going to show it you, but there's increasing evidence that, sorry, I can't see my slide because trying to, oh, there we are, okay. Increasing evidence that in randomized clinical trial, ALBI grade predicts subgroups that respond better to treatment in the actual randomized trials. But that will be published probably at AASLD in the near future. So that's one of the expanding roles for ALBI. The other 2 are in terms of screening and predicting liver failure. So the first of these, published recently in J Hepatology, is the AMAP score. And in the AMAP score, you take ALBI, add platelets, age, and gender, and it predicts very accurately which patients within a surveillance cohort will develop HCC. And here's the figures. So they looked at 17,000 patients, and using the very simple AMAP score, which is age, male, ALBI score, and platelet count, you put those together in this formula and you get a score out of 100, and that reflects the risk of HCC. And in the low AMAP score, there are virtually no patients who develop HCC. In the medium risk, it goes up to around 1%, and in the high risk, it goes up to 4%. And we've just undertaken an external validation, and it seems to work perfectly. And I would anticipate within the near future that we're going to be able to identify patients with cirrhosis who are at virtually zero risk of developing HCC, and they can be offered less rigorous or no surveillance, and you can put all your resources into this high-risk group. The other expanded role for AMAP is in identification of patients with compensated cirrhosis who are going to decompensate. As you know, hepatologists spend a lot of time looking at people with well-compensated cirrhosis who come back year after year. And what you really want to know is which one of those is going to decompensate in the near future. And ALBI lets you do that. This time we add to ALBI FIB4, or a measure of fibrosis. And this is what it does. The ALBI FIB4 index on the vertical axis is the likelihood of remaining decompensation free. Here's 3 data sets, one from the UK, one from Egypt, and one from Ireland. And we can split the patients into those at high risk of decompensation. So you can see this top line here. This group is easily identifiable using this index. You can see at 5 years, the likelihood of remaining decompensation free is nearly 90%. Same in Egypt, same in Ireland. But if you're in the poor risk group, by 5 years, about 50% of patients have decompensated. And I'd remind you that at time 0, all these patients have compensated cirrhosis. So it certainly tells you which of your patients are likely to decompensate. We're currently investigating the possibility of looking at changes in the ALBI FIB4 index rather than the absolute value, and that appears to be even more accurate. Of course, this is entirely clinically plausible. This is a nice qualitative description of the natural history of cirrhosis, published in Gut in 2015. And it describes how patients with cirrhosis have a long period of mild disease and few complications. Then it progresses, advanced fibrosis with compensated cirrhosis, and then it decompensates. That's the natural history described qualitatively. If we now take a large group of patients with cirrhosis and plot out their ALBI score, this is what it looks like over 20 years. Long period when nothing happens, then they start to decompensate at this point. Typically, ascites arrives here, get gradually worse, speeds up towards death, and this is the point at which encephalopathy occurs. You get similar curves for different etiologies, and we can predict accurately the onset of decompensation. So in conclusion, the ALBI score is probably, just like Charles Pugh and Meld, a non-specific indicator of liver health. It has no obvious mechanistic or translational basis, but despite this, it appears to be very useful in clinical hepatology. It's a very accurate way of assessing the prognosis of HCC, especially in patients who are conventionally classified as having normal liver function, or Charles Pugh A5. It tells you about the prognosis of cirrhosis. It's part of an algorithm that can predict HCC development in patients under surveillance. It's part of a prediction strategy for hepatic decompensation, and it seems likely that it can also predict response to some systemic therapies, but that data is not yet published. One of the philosophical challenges for clinicians is this question, and I leave it up to you to answer. If a statistical model is useful, does its mechanism of action matter to the clinician? And you could say that of many different models in clinical medicine. And then finally, I have to acknowledge a huge number of people. We have a data set now of over 250,000 patients with HCC, which allows us to undertake these big international studies. Particularly helpful have been my dear colleagues in Japan, who are generous and give me very accurate data, all my old colleagues from Hong Kong. But the two people who have done most of the work are Sherrie Bhoori, who worked with me for 8 years, and this is my wife. So Sarah did the statistics, and my wife does all the management of this vast, unruly group. This picture was taken when we moved office, and this was a list of all our projects, concept, abstract, submission, publication. And somewhere down there, you can see the ALBI score. Thank you.
Now, I would like to invite Dr. Bruno Sangro. He's the director of the liver unit at Clínica Universidad de Navarra in Pamplona, Spain, and the president of the International Liver Cancer Association. Please, Dr. Bruno.
Thank you very much to Leila, all the organizing team, Rosangela there, for the kind invitation to present today and to share the podium with Professor Johnson. This is always a pleasure for me. My topic today is under this title, New Algorithm for Systemic Therapy for Hepatocellular Carcinoma. Just to say that I have some disclosures in different directions, so nothing really to feel guilty about. And why is there a new algorithm for systemic therapy? Because over the last 13, 14 years, we've seen tremendous advances in the systemic therapy of HCC from an era where I would say very nihilistically, patients were not, patients in need of systemic therapy were neglecting any form of therapy on the basis of the fact that truly HCC has proven highly resistant to cytotoxic chemotherapy over the years, whether it's doxorubicin, 5-FU or combinations, platinum agents or combinations, despite having some objective remissions, probably because of the increased risk of severe adverse events produced by these toxicity and the true intrinsic chemoresistance that made these responses very short-lived. There was almost no universal systemic therapy until sorafenib, the TKI inhibitor, proved to be prolonging the survival of patients in the advanced stage, in the most advanced stages, I would say, versus placebo. This is a very consistent effect of sorafenib, an effect that is only present in the advanced stage. And this applies also for other tyrosine kinase inhibitors like brivinib and others. No effect in combination with local regional therapies in earlier stages. No effect in the adjuvant setting after effective resection or percutaneous ablation. So TKI is being active only in the most advanced stages. It took almost 10 years for another TKI to show some activity in the second line, regorafenib, and then after that, a number of other agents showed either, I will come back to these, non-inferiority in the first line setting or superiority over placebo in the second line setting, including lenvatinib, cabozantinib, and the VEGF receptor 2 inhibitor ramucirumab. But it was only last year when we had the final results from a first combination therapy that beat sorafenib in terms of prolonging survival in patients in the advanced stage. And so, and in the same time over the last 5 years, in some regions, immunotherapies were given accelerated approvals, particularly by the FDA, but not only, on the basis of single-arm trials showing indeed a good number of objective remissions that were durable, that led to very prolonged survival, sometimes even after treatment interruption. So with more players in the field, you need algorithms to organize patient care. This is the Ilka systemic therapy guidance document that you may find online. We decided to put this online because there are the rate at which changes are being developed in this field make these a good platform for doing almost real-time updates. And you will see that atezo-bev, the combination of atezolizumab plus bevacizumab, stands first, is the first choice, and I'll show you why. And then you have different options for patients that are not good candidates for this combination, and you have a number of different options in the second line setting, mainly because there is no scientific evidence for any given therapy after atezo-bev, and we will come back to these later. But let me first show why do we have atezo-bev in the top of the pyramid. These are the results. Most of you would probably know this from the IMbrave 150 trial comparing atezo-bev versus sorafenib. Trial was stopped at the first interim analysis. Now with more prolonged, at that time we didn't even know what the median overall survival was for the combination arm. Now with a more prolonged follow-up, we've learned that more than half the patients live for more than 19.2 months in the atezo-bev arm versus 3.4 months in the sorafenib arm. So it's a reduction in the risk of death of around 33%. Significant amount, I would say, because this comes with improved tolerability versus TKIs and a better patient-reported outcomes, better quality of life, longer time until drop in the tools with which we measure quality of life. These improved overall survival was observed in all subgroups of patients and come with a quite encouraging 30% response rate. So almost 1 out of every 3 patients have an objective remissions, and we know that objective remissions lead to a very prolonged survival. And that includes 8% complete responses. And this is absolutely unprecedented. It means that we for the first time are able to see patients with vascular invasion or extrahepatic metastases being disease-free 3, 4, 5, 6 years after treatment. This very morning, I visited our longest disease-free survivor, a lady with lung metastases bilateral from a resected HCC. that has been disease-free for the last 7 years. And who are the candidates for these a combination? So if we look at the inclusion and exclusion criteria, they are all patients in the advanced stage. That means patients with extrahepatic metastases, vascular invasion, all those patients in which, despite being liver-only disease, the bulk of disease makes intraarterial therapies not a good option. Usually these patients have cancer-related symptoms, and therefore that's the population in which one has to think about prescribing this combination therapy of atezolizumab and bevacizumab. The only exceptions are those patients, on the one hand, that have active autoimmune diseases in need of therapy, of immunosuppressants. That includes liver transplant patients. Then, on the other hand, patients with significant cardiovascular comorbidities, making anti-angiogenics not a good options because of the increased risk of cardiovascular toxicities. And for this combination, patients with esophageal varices that were not properly taken care of, so they were not under beta blockers or having been ligated, were not included either. So those are the main factors that we have to take into account when prescribing or when looking for other alternatives. And there's been lots of debates over the last few weeks or couple of months, because clinical trials did not provide any clue as to whether we could select patients for these immunotherapies in general, the atezo-bev in particular, based on patient characteristics, age, gender, or tumor characteristics, vascular invasion, high alpha-fetoprotein, expression of the PD-L1, the ligand for PD-1. And very recently, there was a publication in Nature from a German group of mainly basic researchers, where they provide good evidence in animal models that immunotherapy with checkpoint inhibitors could lead to tumor progression rather than tumor regression. But this was accompanied by a meta-analysis that you can see in this slide, where they integrated data from 3 different trials, having different treatments. Checkmate 459 testing nivolumab versus sorafenib, IMbrave 150 testing atezolizumab and bevacizumab versus sorafenib, and Keynote 240 testing pembrolizumab versus placebo. So indeed, a very heterogeneous groups of patients and treatments that make these analyses just good for hypothesis generation, and certainly not something that would or should impact clinical practice, particularly when you see that the chances that obtaining an objective remission are the same for hepatitis B, hepatitis C, and uninfected patients. So etiology should not be considered a patient selection factor. So if a patient has a specific contraindication for atezo-bev, then the options are, of course, sorafenib or lenvatinib. It's important to remember that there is no single treatment that has proven superior, no single TKI that has proven superior to sorafenib. Lenvatinib is only non-inferior. This non-inferiority was tested in the REFLECT trial. You see the survival curves. These survival curves were tested for non-inferiority, and that test was positive. So we can definitely say lenvatinib is not inferior, but then it was tested for superiority. And lenvatinib failed to prove that survival was better in the lenvatinib arm versus the sorafenib arm. And this despite the fact that more patients showed some signs of tumor regression, including the number of objective tumor remissions. So despite this potentially high anti-tumor activity, overall survival was certainly not superior. But at least is this one option. And then when we move to the second line, you see the differences between the three different options, regorafenib, cabozantinib, and ramucirumab. There are no significant differences. Hazard ratios are similar between 0.6, 0.7. And post-hoc analysis of subgroups also tell us that etiology, tumor burden, AFP are no key factors in the defining the treatment benefit. Of course, for ramucirumab, only the population of patients having alpha-fetoprotein levels higher than 400 nanograms per mil were included. And these, on the one hand, indicates that the differences in the TKI activities of all these drugs, we don't know whether they have an impact in the clinical activity, but if there is any impact, it's a small impact because they don't translate into a very different clinical profile or therapeutic profile. And one question that always arises, and probably will come in the Q&A section, is, so is there any room for single-agent immunotherapy given that these agents were available in many different regions and countries? I do believe it is, because patients with comorbidities in which sorafenib or lenvatinib, but also bevacizumab, are not good options. And I'm thinking particularly of patients with recent myocardial infarction, with peripheral arterial disease, in which anti-angiogenics may put patients at risk of severe complications like another myocardial infarction or the need for surgery for ischemic ulcers, etc. I do believe that based on the data we have from these two trials that I'm showing, with pembrolizumab versus placebo after sorafenib, or nivolumab versus sorafenib in the first-line setting, showing indeed improved survival, although of a magnitude that did not meet these pre-specified thresholds for statistical significance, nevertheless make, in my opinion, a good argument for using them when anti-angiogenics in general are not a good option. And in terms of making decisions in the algorithm, where we start from when we switch to another therapy, I think there's also another fact that we have to take into account, that is that with immunotherapies, including atezolizumab, we see a number of unique patterns of response that we rarely see with TKIs and chemotherapy, which are pseudo-progressions, tumors enlarging and then showing objective, sometimes complete responses, or delayed responses occurring 6-9 months after treatment initiation, or what we may call asynchronic responses or asynchronic progressions, patients that may have a single site of new tumor, but overall the burden of disease remains stable. And therefore, one has to be careful not to switch too early, also not too late, for different second-line options. And this is just a personal opinion. I think unless there is a massive or clinically relevant progression in the first evaluation. One has to be patient and follow up the patient for a further time. If progression is confirmed, then of course there are other options and patients should be switched to second-line therapies. But if not, if the overall response is stable, let alone if it's objective remission, then patients should be kept on treatment provided tolerability is good. So if based on these data, we now come back to the algorithm, what you see here is that if Atezo-Bev is not an option, so patient is treated with a TKI. If the TKI is sorafenib, we have a very strong evidence supporting either cabozantinib or regorafenib, provided the patient is sorafenib tolerant, or ramucirumab, provided the patient has a high alpha-fetoprotein levels. And in the United States and some Asian countries, the combination of ipilimumab and nivolumab is also an option. If a patient is treated with lenvatinib, then there is no evidence at all. And so probably one may choose from one of the other TKI inhibitors or ramucirumab based on the tolerability and I personally believe patient preferences based on the toxicity profile. And if a patient is a good candidate for Atezo-Bev, as most patients are, and this is the first-line option, then there is indeed no argument to choose one TKI over the other. At least this was the opinion of our panel, and I have to say that I agree with this. The preeminence of sorafenib or lenvatinib cannot be maintained in this setting, and therefore either sorafenib, lenvatinib, or cabozantinib could be relevant, applicable options. And with this, I would like to stop here, and before the Q&A, invite you, as the president of Ilka, to the next Ilka conference that will be, unfortunately, still a virtual event early in September. There are lots of good things that will be presented, and for young practitioners and researchers, there is a BMS initiative that will be covering the fees for registration for a very good number of people that would like to register. So please feel free to apply for these opportunities, and I hope to see you there soon, even virtually. Thank you very much.
Excellent presentation, Dr. Sangro. Thank you very much. And now Dayse will present the next speaker.
Agora eu vou apresentar a professora Rosângela Teixeira para o caso clínico número 2. A professora Rosângela Teixeira é professora titular do Departamento de Clínica Médica da Faculdade de Medicina da Universidade Federal de Minas Gerais, coordenadora do ambulatório de hepatites virais do Hospital das Clínicas da Universidade Federal de Minas Gerais, membro do Serviço de Gastroenterologia e Hepatologia do Hospital Felício Roxo, em Belo Horizonte. Professora.
Boa tarde a todos. Eu queria inicialmente dar os parabéns à minha querida amiga Leila, pelo honroso trabalho em prol da ciência da hepatologia brasileira. Leila, que há 25 anos, como ela apresentou, ela está no caminho do conhecimento, né? E um trabalho gigantesco, hercúleo, um grande investimento pessoal para que nesses 25 anos a gente tenha o melhor da ciência e da hepatologia brasileira. Parabéns, Leila, fico muito honrada de estar participando mais uma vez. Muito obrigada. I would like to congratulate the speakers and Brazilian colleagues to the brilliant talks, and my special welcome and thanks to Dr. Bruno, who kindly received me in the Pamplona for the sabbatical training in 2019. Very welcome. And now I will present a real clinical case, and I will be happy to hear from all of you regarding the questions. So I will share my screen. Leila pediu que a gente apresentasse em português, mas os slides vão estar em inglês. Espero que, I hope that everybody can understand me. Ok, esse é um caso que eu gostaria de apresentar juntamente com a nossa equipe do Hospital Felício Roxo, em Belo Horizonte. Nós estamos situados aqui na região sudeste, né, do Brasil. É um hospital de atenção terciária para tratamento dos pacientes com nódulos hepáticos, aqui a nossa equipe multidisciplinar. Então, é um prazer estar aqui representando todos nós. Então, a história do paciente é um homem de 58 anos, nascido em Manhuaçu, Minas Gerais, né? Sabidamente uma região endêmica de esquistosomose. É interessante a gente falar que a esquistosomose ainda é um problema no Brasil, né? Embora a gente tenha uma diminuição muito importante dos casos de esquistosomose aguda, nós sabemos que há um percentual muito grande ainda de pacientes com esquistosomose crônica, sobretudo forma hepatoesplênica, e associada a outras hepatopatias. Então, esse paciente, em 2018, ele teve o diagnóstico de uma esquistosomose hepatoesplênica e uma cirrose criptogênica com a hipertensão portal muito importante e vários shunts portosistêmicos. Isso é bastante frequente, né, em pacientes com esquistosomose. E o que acontecia de mais importante do ponto de vista clínico, esse paciente não fez nenhum episódio de hemorragia digestiva alta, mas ele apresentava recorrentes episódios de encefalopatia hepática desde 2016, possivelmente associada a esses shunts intraabdominais. Não havia história de abuso de álcool e todos os testes para outras hepatopatias sorológicos e autoanticorpos foram negativos, e a comorbidade era um diabetes tipo 2, controlados com hipoglicemiantes orais. Não durante toda a análise, tanto clínica quanto epidemiológica ou laboratorial, não se identificou outra etiologia que pudesse explicar a cirrose hepática desse paciente. Então, esse paciente foi admitido com um estado geral bom, performance status 0, o índice de massa corporal de 24, o exame clínico revelava, de fato, uma hepatoesplenomegalia, mas não havia nenhuma evidência de descompensação hepática. Na ocasião, em setembro de 2018, os exames mais importantes, então, revelaram a bilirrubina total de 3,5, INR de 1,4, creatinina 1,2, albumina de 3,4, caracterizando, então, um score de Child-Pugh de B8 e um mel de sódio de 17. Então, os exames iniciais, logo da entrada do paciente no serviço, a primeira ressonância magnética, né, revelou 3 nódulos hepáticos de 4,6 centímetros, 1,3 e 1,2, todos com washout, caracterizando o Lehigh de 5, e já nessa ocasião, setembro de 2018, o paciente apresentava uma alfa-feto bastante alta, né, de 538. A cintilografia óssea e a tomografia torácica foram negativas para metástases extrahepáticas. E com esse quadro, né, o paciente foi, então, listado para transplante e após a decisão de fazer o downstaging dessa lesão maior de 4,6 centímetros. Então, em síntese, nós estamos com um paciente de 58 anos, uma cirrose criptogênica e uma esquistosomose hepatoesplênica, uma hipertensão portal muito importante, clinicamente significativa, com varizes de grosso calibre, vários shunts portosistêmicos, recorrente episódios de encefalopatia hepática. Ele era, desde o início, uma carcinoma hepatocelular Milan alto, mas sem invasão vascular, não havia, na ocasião, metástases extrahepáticas e um Child Pug Score MEL de B8, e MEL de sódio de 17. Bom, na linha do tempo, então, o que nós observamos? Então, em setembro de 2018, foram essas 3 lesões detectadas à ressonância, sem invasão vascular, alfa-feto de 538, como a gente colocou. Em outubro de 2018, então, ele foi submetido a Dayse com uma tentativa de downstaging aí, não necessariamente o downstage nesse momento, mas a intenção era que a gente pudesse reduzir o tamanho da lesão maior até o transplante. Então, em dezembro de 2018, 2 meses, o controle, pós-Dayse, o exame, a ressonância já revelou uma resposta muito importante dessa lesão maior, mas notamos algum pequeno crescimento das outras lesões e 2 lesões menores de 1 centímetro com washout, mas sem invasão vascular. E o muito interessante é que, nesse momento, a alfa-fetoproteína teve uma queda significativa após Dayse, a alfa-feto era 538, 3 meses após, alfa-feto 158. Então, esse paciente, em março de 2019, ele foi submetido ao transplante, de acordo com a legislação brasileira, com a portaria ministerial aqui de 2019. Então, o que aconteceu no pós-transplante? Então, ele foi transplantado com uma alfa-feto bem reduzida em relação ao quadro inicial. Em novembro de 2019, o paciente queixava de um desconforto pélvico. Então, no seu segmento, em razão dessa queixa, foi feito uma tomografia que mostrou uma lesão lítica no osso ilíaco, de 5,5 centímetros, mais uma alfa-feto bem baixa, após o transplante, uma queda significativa após o transplante. Isso em novembro de 2019. Então, a proposta foi iniciar uma medicação sistêmica, foi iniciado, então, o sorafenib, e a imunossupressão foi substituída por everolimus. Em maio de 2020, então, o paciente se apresenta durante o controle com piora, com uma progressão da doença extrahepática, das metástases extrahepáticas. E aqui já surgiram nódulos, vários linfonodos peripancreáticos e também uma lesão na adrenal direita e a lesão do osso ilíaco, que inicialmente era de 5,5 centímetros, agora 7 centímetros. E surpreendentemente, uma elevação muito importante da alfa-fetoproteína. Então, isso em maio de 2020, a conduta, então, em função dessa progressão e da boa tolerância do paciente ao sorafenib, foi iniciar o regorafenib. Bom, e em dezembro de 2020, no segmento aí, o paciente piorou. Ele teve mais lesões e agora já com lesões na região vertebral, no manúbrio externo, mais lesões em linfonodos, ele mantinha um performance status bom, mas a alfa-fetoproteína, sim, em elevação progressiva, que uma alfa-feto muito alta, com uma boa tolerância a regorafenib, e a conduta foi, então, a gente substituiu o regorafenib por cabozantinib. E, a partir do cabozantinib, o paciente se mantém estável, não apareceram novas lesões, ele teve uma perda de peso, performance status atual de 1, e a alfa-fetoproteína com uma leve queda em relação à anterior aqui, de 36.729, o paciente se mantém estável em uso do cabozantinib. É interessante observar que durante toda a evolução terapêutica dele, desde novembro de 2019 até agora, o paciente não teve grande toxicidade, os regimes foram bem tolerados e as lesões agora estabilizaram com o cabozantinib até o momento. E o paciente ainda bastante motivado, assim, desejoso de que seu tratamento seja continuado. Bom, então, em razão dessas manifestações severas, né, pós-transplante, né, um quadro com uma evolução ruim, a gente gostaria de fazer algumas perguntas e para a nossa discussão. Então, a primeira questão que eu gostaria de ouvir é que se há uma sequência ideal de tratamento sistêmico para recorrência progressiva no pós-transplante. Será que deveríamos considerar o tratamento sistêmico distinto daquele que é realizado em pacientes não transplantados? Outra questão que eu acho importante, nós estamos vendo aqui discussão dos scores, né? Os scores são muito importantes na nossa prática, é frequente a gente usá-los, então eu gostaria de saber se é válido incorporar sistemas de score prognósticos para recorrência pós-HCC na prática clínica. E eu gostaria de ouvir, sobretudo, aí do Dr. Bruno, a respeito do papel da imunoterapia, né? Antes, para down stage, né? Foi bem comentado aqui pela doutora Sherrie, ou então após o transplante. Será que nós existe alguma possibilidade da imunoterapia agora, ou breve, né, daqui a pouco tempo? Será que vai ser possível utilizar esse tratamento que tem sido tão importante em pacientes no contexto fora do transplante? Será que esse tratamento poderia, de alguma forma, um dia vir a ser usado no pós-transplante, né, beneficiaria os pacientes? Então, são essas as questões, e eu vou agradecer mais uma vez a participação.
So I was saying, I'm not sure I will remember all the three different questions. So I'll start from the last one, which I remember well. And the short answer is it's not in the horizon. Why am I saying so? It's clear that the PD-1, PD-L1 axis has a key role in rejection of the graft for any solid organ transplantation. And it is true that there have been some very few case reports of uneventful treatments, but it's also true that there have been some reports of corticoresistant, treatment-resistant in general, rejections leading to death. So I think it's really extremely difficult to identify patients from what we know today that could not develop graft rejection if you use immunotherapy with PD-1, PD-L1 inhibitors. So unless within a clinical trial in which somebody may do a liver biopsy, see what is the level of PD-L1 expression, etc. Unless in this framework for general practice, I think liver transplantation should be considered an absolute contraindication for the use of immunotherapies. A much different thing is whether patients that experience important tumor remissions with immunotherapy that put them in a situation where there is only limited liver disease, small burden of disease within the liver, whether these patients could be transplanted or not. And my personal opinion is yes, provided you provide a washout period so that the patient goes to liver transplantation once there is no receptor occupancy for PD-L1, PD-1 inhibitors. So you stop treatment with checkpoint inhibitors. Depending on the half-life of the checkpoint inhibitors, you wait a certain time, and then you list the patient and you transplant the patient. What the experience is that in that situation, treatment is safe and transplant can be accomplished safely. And this takes us to an unresolved question, which is, if you have a long waiting list and the patient is expected not to be transplanted until 8, 9, 12 months later, does it make sense to use immunotherapy to prevent rejection? There is a good rationale for that. There is some evidence suggesting that checkpoint inhibitors may induce more potent anti-tumor immunity in the neoadjuvant setting than in the adjuvant setting, when you have the tumor there in situ. And so there is rationale for using immunotherapy. But I think this has to also to be done in the setting of clinical trials.
Yeah. Yeah. What about the sequence of treatment, a systemic treatment after liver transplantation? What do you think?
I don't think there is anything different than in non-liver transplant patients. We have cohort data for lenvatinib, for regorafenib, and we will have soon for cabozantinib. We have what we do is exactly what you have done. We first use sorafenib, and then upon progression we use either regorafenib or cabozantinib. And I have to say that we have seen, as in your case, not only stable diseases but also objective remissions with cabozantinib after lack of response to sorafenib. And this brings us an interesting question, whether these differences in TKI inhibition, tyrosine kinase inhibition spectrum may be more relevant in the liver transplant patients. But yes, I think the choice of cabozantinib or sorafenib or lenvatinib, I think is a personal one. I think the toxicity profile is very important there.
Thank you, Dr. Sangro. Thank you. I would like to hear from Dr. Sherrie, the experience with the PD-1 as a bridge to liver transplantation. How is it in your center? Dr. Bruno, have you experienced with this bridge with PD-1 to transplant?
Yes, exactly. Patients that respond well, we don't use this as a bridging therapy on purpose. Okay. So because in Spain we have a very short waiting list now. We have a very high donor rate, as you know, and now with eradication of hepatitis C, the indication of liver transplantation because of hepatitis C has dropped absolutely.
Yeah.
And so the balance between donation and transplant is fairly good, and the waiting list is quite short. It's very difficult now to be waiting for a liver transplant for more than 6 months. And so bridging therapy in our environment doesn't make sense. But what we have experienced is in patients that have been downstaged with immunotherapy and reached the criteria for being transplanted. And we are considering transplanting these patients.
Wow, perfect. Thank you.
Yes. May I?
Of course.
Yes, Dr. Flair.
Yes. Hi, Bruno.
Hi, Flair.
in this case, of course, this patient has just now around 3 years of survival since the diagnosis.
Yeah.
And our Brazilian system offered the possibility of downstage in case like that it has advanced HCC. This patient had 5 nodules with advanced, and of course he has a good survival, a good response to cabozantinib and all. But you think that in this patient, I don't agree with the Brazilian system. You think that in this patient, in Europe, you use to indicate the liver transplant in a patient with 5 nodules, with the alpha-fetoprotein so high. It has a behavior, a biology, a behavior of advanced liver disease. And in Brazil, we don't have so much donors like in Spain. And in my department, we would discuss at the multidisciplinary team the indication of the liver transplant. Of course, we have our Brazilian system permit to treat patients like this one, and we have a response with the 3 years of survival. But this is a response independent of the liver transplant or not. I would like to ask for the Bruno and Sherrie and the others, Ilka, and all the colleagues.
Well, to answer the question, in many countries in Europe, this would not have been possible because there are important restrictions. For instance, in Germany, where they have very few donors, you may not transplant outside Milan Criteria. In other countries, now the situation is more flexible in terms of number of nodules, but more restrictive based on alpha-fetoprotein. And I think the updated metro ticket developed by the Milan group is used quite widely in, I would say, in European centers, and therefore it's not only number and size of nodules, but alpha-fetoprotein is very important. I also feel that alpha-fetoprotein is extremely important, and I remember having very good discussions with Phil Johnson about this and the relations with the ALBI score, because high alpha-fetoprotein reveals issues about the biology of the disease that are very informative, and therefore I think in the presence of a patient with high alpha-fetoprotein, the downstaging criteria have to be sustained over time to make sure that really you are in control of the disease. But this is a personal opinion.
Yeah. Let's do some consideration. If we,
Angela,
okay,
please, we have to finish. Only 5 minutes.
Sorry.
I have to, before you finish, I think if you could be commenting anything about the ALBI and the Christian, I have only 5 minutes to close this section, unfortunately, but time to close it. Phil, could you, about the score? That's
Dr. Phil.
Sangro.
Please talk about the ALBI score and liver resection. After liver resection and after liver transplantation has a predict factor.
And before liver resection.
Okay, so the easiest question is what happens is the ALBI score any use before transplantation? And the answer is no, because effectively you get normal liver function after transplantation. And ALBI1, ALBI2, ALBI3, if people have a successful transplant, the outcome is identical. If you're ALBI1, you survive twice as long after resection as if you have ALBI2. Now, I'm not saying why that is, but it is a fact of life.
If I can add, we have integrated this into a clinical practice and now only perform very limited liver resections, subsegmentectomies or small segmentectomies if the patient is ALBI2 or ALBI3. So we only perform significant hepatectomies in ALBI1 patients.
Agreed. Okay, so I think that's, I mean, it's very reassuring for us, since ALBI is my child, that it's actually getting into clinical practice. I think it's going to come. I think it's going to come. But we will see.
Cristiane, do you have only 1 minute to comment? Based on how your experience in Brazil, especially in our city, because you have the time is run out now, please, sorry.
Yes, I understand.
Okay, I understand.
I'd like to congrats Dr. Sangro. It was an excellent presentation. And I would like, Doctor, to know if you have a time post-transplantation to think about immunotherapy. Because I received a patient that had transplantation, was submitted in a transplantation 20 years ago, and the hepatologist said she was released to do immunotherapy. What do you think about that?
I would be very cautious. I would tend not to use immunotherapy, but if there is pressure to do that, if the patient wants and there is nothing else to do, and certainly what I would recommend is to do a liver biopsy and check for PD-L1 expression. If there is PD-L1 expression in the lymphocytes, I would certainly avoid using immunotherapy in these patients.
Okay, thank you.
Unfortunately, the time is run out. I'd like to say thank you very much indeed for all the participants. You have 98 participants in this round table today. Thank you very much for international speakers to take our time to join us. And I hope it was good to see you anytime this year or probably next year together. And invited the Sandro and the Phil and Sherrie to visit the Recife, visit Brazil. You have a beautiful sunshine all the time and beach to enjoy scientific program together. See you soon. See you next.
Thank you.
Looking forward.
Okay.
Thank you.
Sandro, please, can you send your lecture, Sandro, to us, please? I have to put them, okay?
Thank you,
Picture, Leila.
Bye-bye.
Leila, the final picture, please.
Thank you.
Yeah, define the pictures. Okay. Take a picture, Lani, please.